Good day. So we are group 4 and we will be discussing the different parasitic protozoa under phylum Amoebozoa and Percolozoa. The first genus under the kingdom Protozoa is Acanthamoeba. This is under the phylum Amoebozoa, class Lobosea, order Amoebida, and family Acanthamoebidae. The most common or most known species of Acanthamoeba that is responsible for the most reported cases of human infections caused by this genus is the species Culbertsoni. This 18S RNA-based phylogenetic tree by Schmitz et al. In 2008 found out that most clinical and environmental isolates belong to the morphological group 2 and the genotype T4. Through restriction fragment length polymorphism, or RFLP, it was discovered that almost all clinical isolates, including one from a granulomatous amoebic encephalitis, belong to the genotype T4. Several of the environmental isolates were observed to have belonged to the genotype T4 as well. Acanthamoeba are free-living amoebae. Hence, they do not require an insect vector in order to infect humans, but they are a host to viruses, yeasts, protists, and bacteria, which are potential human pathogens. It's also important to note that Acanthamoeba are soil or water commensals. Hence, infection will commonly occur or will usually occur through contact with infected soil and water through the eyes or contact lens. And as I've mentioned before, Acanthamoeba culbertsoni, formerly termed as Hartmanella culbertsoni, is the most responsible Acanthamoeba for human infections. Other species include Acanthamoeba polyphaga, A. castellani, A. astromyxes, A. byersi, A. hatcheti, A. haley, A. astronixis, and A. divionensis. The phylum Amoebozoa and the phylum Percolozoa differ from each other based on their life cycle. Amoebozoa will lack flagellated forms, while Percolozoa will have flagellated forms in their life cycle. This distinction in their life cycle, whether or not they will have flagellated forms, will or is important in epidemiology, especially in diagnosing a disease. For Acanthamoeba, since it is under the phylum Amoebozoa, exists in two forms, the cyst form and the trophozoite form. Its name from the Greek word acanth. It roughly translates to spikes due to the presence of spine-like pseudopodia called acanthopodia in its trophozoite form, while in its cyst form, it possesses polygonal double walls that allow it to be highly resistant to its environment. Unlike in the genus Naegleria, under phylum Percolozoa, as I mentioned, Acanthamoeba only has two stages, the cyst stage and the trophozoite stage. The trophozoites replicate by mitosis, in which the nuclear membrane does not remain intact. The trophozoites are the infective forms, although both cysts and trophozoites gain entry into the body through various means. Entry can occur through the eye, the nasal passages to the lower respiratory tract, or ulcerated or broken skin. When Acanthamoeba enters the eye, it can cause severe keratitis in otherwise healthy individuals, particularly contact lens users. When it enters the respiratory system or through the skin, it can invade the central nervous system by hematogenous dissemination, causing granulomatous amoebic encephalitis or GAE, or disseminated disease, or skin lesions in individuals with compromised immune systems. Acanthamoeba, cysts, and trophozoites are found in the tissues. For the diseases caused by Acanthamoeba, we have chronic amoebic keratitis or keratophatis. Keratophatis is an active corneal disease associated with anterior chamber inflammation. This is a serious eye infection that can cause permanent vision loss or blindness. 85% of cases occur in contact lens users, and it develops from the entry of amoebic cyst through abrasions on the cornea. It can be acquired by inhalation, ingestion, or through traumatized skin or eyes from contaminated water. And unlike the diagnosis for Naegleria fowleri, which will be discussed later on, the diagnosis for this disease is the demonstration of the cyst in the corneal scrapings by wet mount, histology, and by culture. Symptoms include eye pain, blurred vision, sensitivity to light, excessive steering, eye redness, and a sensation of something in the eye. It resembles that of severe herpetic keratitis with a slow relapsing course, but in this case, the amoebic infected eye is severely painful. Granulomatous lesions in other sites other than the eye, such as the skin, the lungs, and the middle ear, have also been reported. The treatment is early diagnosis, which is the most important treatment, along with administration of drugs and necessary surgical procedures. There are no reports of Acanthamoeba keratitis spreading from one person to another. Hence, the most effective way to prevent amoebic keratitis is through the proper storing and handling of lenses and by minimizing swimming, using hot tubs, or showering with lenses. Another disease caused by Acanthamoeba is the granulomatous amoebic encephalitis, or GAE, which is a fatal infection of the central nervous system. GAE can be acquired through the inhalation of dried cysts or through the skin, which could spread to the brain through the bloodstream. People who are at risk are the ones with predisposing factors such as steroid use, diabetes, alcoholism, and immunodeficiencies, including AIDS, cancer, disorders in the blood cells, and liver cirrhosis. This condition is fatal and is usually diagnosed at the later stages when symptoms are already severe. Symptoms of GAE include changes in the mental status of the patient, fever, coordination loss, double vision, muscular weakness or partial paralysis affecting one side of the body, sensitivity to light, and other neurologic problems. GAE is difficult to diagnose at an early stage, but tests such as brain scans, spinal taps, and biopsies for disseminated infections may be performed. Currently, its treatment can be quite difficult in immunocompromised patients, but combination therapy using pyrimethamine, sulfadiazine, and fluconazole could be performed together with a surgical resection of the central nervous system lesion. Note, though, that treatment is highly unsuccessful due to late diagnosis. Prospective medicines may also be considered, such as the murine monoclonal anti-idiotypic antibody and synthetic killer mimatope. For the prevention and control, steps that may be taken are still unclear as people with weakened immune systems are more susceptible.
After learning about Acanthamoeba, we now proceed to discussing another parasitic amoeba, which is Entamoeba histolytica. These species belong to the phylum Sarcomastigophora, which is divided into two subphyla, subphylum Sarcodina and subphylum Mastigophora. Entamoeba histolytica belongs to the subphylum Sarcodina, and this subphylum is characterized by amoebas that have no permanent locomotory organs, but instead move with the aid of pseudopodia. Further, Entamoeba histolytica belong to class Lobosea, order Amoebida, and family Entamoebidae, a family that includes parasitic or commensal species of amoebas living in the digestive system of arthropods and vertebrates. The genus Entamoeba includes pseudopod-forming parasitic protozoans that invade the oral cavity or intestinal tract of vertebrates and invertebrates. Now, Entamoeba histolytica is the most commonly occurring pathogenic amoebic species that invade the gastrointestinal tract of humans. So they are restricted in the GI tract of humans and other primates and can also be found in the feces where they are transmitted. They can also live as commensal species for many years. This figure shows the phylogenetic tree of Entamoeba histolytica. Unique tRNA gene arrays within the genus were used to elucidate their pattern of evolution. Previously, Entamoeba histolytica was thought to have diverged early from the eukaryotic line, but later studies showed that it has descended from ancestors that possessed mitochondria. Other species from the genus can be observed in this phylogenetic tree, one of which is Entamoeba dispar, a non-pathogenic entamoeba first considered to be sibling species with Entamoeba histolytica due to similarities in the morphology of their cysts and trophozoites. It is only recently that they are accepted as different species due to notable molecular differences in the type of their NK arrays. Unlike Entamoeba histolytica, the species of Entamoeba dispar are considered to be non-pathogenic, although they were also shown to be capable of producing intestinal lesions in experimental animals. Another species from the genus Entamoeba that can be observed from the figure is Entamoeba moshkovskii, and this is also morphologically identical to Entamoeba histolytica, especially in the appearance of their cysts and trophozoites. This often makes diagnosis between these two species difficult. Similar to Entamoeba dispar, the species of Entamoeba moshkovskii is also non-pathogenic, although they can also establish in humans and have also been found to induce diarrhea in Bangladeshi children, as well as diarrhea, bloody stool, and weight loss in susceptible mice. Other non-pathogenic species from the genus Entamoeba include Entamoeba hartmanni and Entamoeba coli, which are also commensal intestinal amoebas. Entamoeba polecki is another species originally found as intestinal parasites of pigs and monkeys. These are also detected in human intestines in some parts of Southeast Asia, but they do not appear as human pathogen. The first described amoeba in humans is Entamoeba gingivalis that lives in the gingival tissues, as the name suggests. They have a global distribution, but they are considered as commensal and are also non-pathogenic. Since Entamoeba histolytica is a human pathogen, the host of these parasitic species then is humans. However, they can also be found in primates, and cases of infected dogs have been documented. For instance, fecal samples of some dogs exhibiting diarrhea, dysentery, and vomiting in Pakistan were positive with Entamoeba histolytica, Entamoeba dispar, and Entamoeba moshkovskii cyst. Entamoeba histolytica were also found in one German Shepherd dog, which showed symptoms of weight loss, diarrhea, vomition, halitosis, and salivation. In terms of vectors, there are no known vectors of Entamoeba histolytica, although some flies and cockroaches may potentially act as mechanical vectors after viable cysts and their droppings were found for a day or two after exposure. Because Entamoeba histolytica is a human pathogen, it causes amoebiasis or amoebic dysentery, a disease characterized by moderate to severe gastroenteritis, which in advanced cases may lead to anemia and liver abscess that can spread to other organs such as the lungs and the brain. Entamoeba histolytica has two forms, the trophozoite and the cyst, which are both passed in the feces. The trophozoites are the growing or feeding stage of the organism, about 20 to 40 micrometers in size, and are motile due to the presence of short and blunt pseudopodia. When trophozoites are passed in stool, they are rapidly destroyed once outside the body, and if ingested will not survive the acidic environment of the stomach. Now the cysts are the infectious form of Entamoeba histolytica. They are round, about 10 to 20 micrometers in size, and are resistant to the external environment enabling them to survive and remain infectious for many days. Mature cysts of Entamoeba histolytica can be ingested by humans through fecally contaminated food and water, contaminated hands of food handlers, and exposure to infectious cysts and trophozoites during oral anal sexual contact. After ingestion, excision of the cyst happen in the small intestines as the cyst wall is damaged by trypsin. The trophozoites are then released and they migrate into the large intestine. They may remain in this organ or they may begin colonizing other parts of the body. Trophozoites that invade the intestinal mucosa will cause intestinal diseases, while those that invade the blood vessels will reach extraintestinal sites such as the liver, brain, and lungs to cause extraintestinal complications. Those that remain in the intestinal lumen causes non-invasive infection and may continue to pass cysts in the stool. Specifically, the trophozoites will lodge into the glandular crypts of the cecal mucosa and undergo binary fission. Some of the resulting trophozoites from this division will undergo a precystic stage before undergoing encysement. During the process of encysement, the precysts secrete a highly refractile hyaline cyst wall to become a cyst, which will then be released again outside the body through the stool to begin the life cycle. In terms of epidemiology, pathogenic Entamoeba occur worldwide and are frequently recovered from fresh water contaminated with human feces. The incubation period is variable, usually from 2 to 4 weeks, but may also range from a few days to several months. About 50 million people are infected by Entamoeba histolytica, and these are responsible for about 100,000 deaths annually. As for the clinical manifestations, most of the infections restricted to the lumen of the intestine are asymptomatic. However, invasive intestinal diseases manifest through several weeks of cramping, abdominal pain, watery or bloody diarrhea, and weight loss. In severe cases, further complications such as peritonitis, perforations, and the formation of amoebic granulomas called amoeboma could also develop. Meanwhile, extraintestinal diseases are usually manifested by liver abscesses. However, pleuropulmonary abscess, brain abscess, and necrotic lesions on the perianal skin and genitalia have also been observed. Pneumonia, purulent pericarditis, and even cerebral amoebiasis have also been described. As for the treatment, drug therapies can be used to treat amoebiasis. Luminal amoebicides such as iodoquinol, diloxanide furoate, and paramomycin that act on the organisms in the intestinal lumen can be used for patients with intestinal and asymptomatic infections. These drugs eliminate disease from the intestinal tract. Now, since Entamoeba histolytica is ingested from contaminated water, one important method of prevention is to ensure clean drinking water by filtering or boiling tap water. It is also crucial to practice good hygiene and sanitation by washing hands with soap and water and avoiding the consumption of raw vegetables or fruits not thoroughly washed or prepared. Sanitary disposal of fecal matter is also important, as well as the protection of food and drinks from houseflies or cockroaches because they may serve as vectors of the organism.
Naegleria belongs to the kingdom Protozoa, phylum Percolozoa, subphylum Circodina, superclass Rhizopodia, class Percolozoa, order Schizopyranida, family Vulcampidae, genus Naegleria, and the one that we will deal with, the species Paulari. For its phylogeny, as you can see at the bottom of the tree, Naegleria are Percolozoa, a group of colorless protozoans that are able to shift among amoeboid, flagellated, or encysted forms. There are three species given here: the N. gruberi, N. lubaniensis, and the N. fowleri. We will focus on the solely pathogenic species, the N. fowleri, which is quite known as the brain-eating amoeba. For its host, it affects healthy children and young adults through entering the nose. There are also documented cases of infected cattle and a South American tapir. It has no vector. As we have said, infection only occurs when N. fowleri from contaminated warm fresh water enters the nose. Its disease is called primary amoebic meningoencephalitis or PAM. Before we talk about its life cycle, let us first discuss the three stages of the N. fowleri: the dormant cyst form, the amoeboid trapezoid form, and the flagellate form. Well, that is why it is classified as amoeboflagellate. Cyst form is spherical, 7 to 15 micrometer in diameter. It is the resting form, developed when trapezoids are under environmental stresses. They cease to increase chances of survival. They are termed as thermophilic as they can resist up to 45 degrees Celsius. For its amoeboid trophocyte form, its size is 10 to 35 micrometer with rounded pseudopodia. That is why it is called lobopodia. Appears to be granulated with a single spherical nucleus. This is also the feeding, growing, and replicating form through binary division. This division is where nuclear membrane remains intact, thus termed promitosis. Moreover, they are found in water, soil, or surface vegetation. They are also the main infective stage. They can temporarily change to a flagellate form when environmental factors are not conducive for growth. Lastly, its flagellate form, pear-shaped form with two flagella. This can revert back to trophozoite form when environmental factors are conducive for growth. Moving on for its life cycle, trophozoites and flagellate forms enter the nose of a person swimming or diving in a contaminated, warm freshwater. And fowleri invades nasal mucosa, attaches to the olfactory nerve, then branches in the cribriform plate into the meninges and brain, causing acute primary amoebic meningoencephalitis or PAM. Dissecting the words, meningitis means infected meninges, encephalitis means infected brain. So when joined together, it means infected meninges and brain. This disease almost always ends fatally within a week. Trophozoites are found in cerebrospinal fluid, CSF, and brain tissue. Flagellate forms in CSF, while cysts are not found in the brain tissue. So what's the importance of this? Uh, the importance of flagellate forms found in CSF is that it differentiates Naegleria infection from amoebic infection and subsequently proves that Naegleria is rightly under class Percolozoa and not Amoebozoa. Just additional background information. The older classification grouped Naegleria with Acanthamoeba under class Amoebozoa. But pathogenic members of Amoebozoa only have two stages, the cyst and the trophozoite form. Moving on to its epidemiology, the incubation period ranges from 2 days to 2 weeks. PAM rapidly leads to coma and death 1 to 18 days after symptom onset. Although seem severe, cases are very rare. In the US, only 151 PAM infections were documented from 1962 to 2020. Among all, only 4 survived. Clinical manifestation. Early symptoms may include headache, fever, nausea, and vomiting. On the other hand, late symptoms may include neck stiffness, lethargy, confusion or disorientation, photophobia, seizures, and cranial nerve abnormalities. Treatment, control, prevention. For its treatment, combination of drugs includes intravenous amphotericin B, other antifungal drugs, and antibiotics. As for its control and prevention, first is to not swimming in or jumping into warm fresh waters. Second is the wearing of nose plugs when participating in recreational water activities. Here's our references for our report. That's all, and thank you very much for listening.